Thank you again, Mr. Chair, and sorry about the struggle to connect. And a great thanks to the organizers of this very fantastic event. Dr. Verenga, great credit to you and to your team. We have discussed the importance of training to identify abnormalities. Of course, one of the big challenges we've faced is what do we do with these abnormalities? How do we manage the abnormalities, and how do we counsel the parents about what they're dealing with? As already mentioned in the previous session by various speakers, there are quite a few reasons why things can go wrong in obstetrics and in fetal medicine. We dealing with genetic defects, with congenital abnormalities, particularly abnormalities of the brain and the heart, the challenges of preterm delivery and the issues of cerebral palsy and the hypoxia. So these are the challenges that we have faced and we have to tackle continuously to improve our care. However, the general public at large thinks that this is an easy fix. And I put this cartoon just to highlight the point that, you know, there isn't such a thing where you put a coin into some fantastic computer and that will give you risks for everything. So in real life, things are a bit more complicated. In countries that are far from our shores, because today this is an Africa conference, in smaller countries that are wealthy, such as Denmark, they're very proud to announce to the world that conditions such as Down syndrome are nearly eliminated. And credit to them. In other countries, and I have put a slide here from the United States of America, where they say, have we gone maybe too far? There are people who are starting to question the need to be so eager in identifying every abnormality there is and terminate every abnormality there is. As you probably all know by now, in some states in the United States of America, they actually started banning abortion. And there is this little side information on the bottom right where I have put in a blurb from a newspaper in Texas where any gestation after 6 weeks should not be allowed to be terminated, regardless of what is the abnormality. And citizens of that country have the right to actually go to the police and report a case where they have discovered that someone terminated, and they get paid for that. So this is perhaps the other extreme, the other side of the spectrum. We as practitioners often run to the courts, we get sued, or we go to lawyers to get legal advice. But our biggest challenge, I think, is the courts may not be equipped to give us all the help that we require to get justice. Is always truth equal justice, or is justice equal truth? And that's something that sometimes is a very complex answer. Moms often say, had I known that my child had Down syndrome or some other abnormality, I would have terminated the pregnancy. And the courts actually often say we're not really equipped to make pronouncements on these decisions, or whether someone should have been allowed to be born or not. Our obligations as medical practitioners, as doctors, and they're very, very well known to all of us who have been practicing medicine, are the beneficence, our aim to try and do good and help our patients, the non-maleficence, where we try not to cause any harm to our unborn patients or to their parents, the respect for autonomy, to allow our parents, our prospective parents, the right for self-determination, and try and provide healthcare across the board in a fair manner. People, and again, the public at large, question this. I've put this cartoon that I put in many years ago in one of my talks, where a doctor says to this couple, Hagar and his wife Helga, you should trust doctors more. Our first rule is do no harm. And she says quietly to the husband, it worries me that they need a rule to figure that out. So let's look at the patient's autonomy in obstetrics. Is an adult with a basic capacity to make decisions may decide what may be done to her body. It includes refusal, actually, of any treatment, even if our opinions as medical practitioners are different. If we look at mothers, surrogate mothers, teenage mothers, and our role as obstetricians, the fetus becomes our patient. We have access to assess the fetus only if that fetus is presented to us by the mother. So that's where the fetus is really solely dependent on its mom to actually become our patient and help. If we look at where do we stand with teenage mothers and their autonomy, the law in South Africa, and I understand by what I have researched in the last couple of weeks, that this would apply in most parts of the world and most countries in Africa, is that any person shall be competent to consent without the assistance of her parent or guardian to the performance of any medical treatment of herself or her child. That includes termination of pregnancy. So a minor may actually decide to have termination of pregnancy without really consent from her parents, although we always strongly advise that such a minor consults her parents before such a decision is made. A very sticky issue with the surrogate moms, and we have seen over the years things going wrong because centers provide now this service, particularly in South Africa, as surrogate moms are renting out, if you wish, or lending their uterus to couples who are unable to have a pregnancy physiologically. So the surrogate mother must already have one child and one successful pregnancy herself. She may not commercially gain from such a pregnancy agreement. The surrogate mother relinquishes all parental and contact rights with the child. It can only have contact or relationship status according to the agreement with the biological parents. Should the fertility treatments, however, start before prior confirmation of these agreements, the surrogate mother may end up being the rightful parent. And this has happened in the past. The agreement must furthermore stipulate obligations, parental rights, and conditions of contact termination. And it is essential to discuss all these things before actually anything is signed in a court of law by experts in the field of this. So let's move to the unborn patient. Does actually a fetus have its own moral status? The law states that a fetus does not possess independent moral status, does not generate its own rights, and there cannot be autonomy-based obligations to any fetus. Nevertheless, the human embryo has been given a special status. So we cannot really do anything we want with human embryos just because a human embryo doesn't have an independent moral status. And there are rules around the world stipulating what can be done on human embryos. The issue of termination of pregnancy, and this is the South African Act. I understand and I appreciate that in many countries around the world, this may be slightly different. But just to summarize what this busy slide says is that upon request, any woman can request termination of her pregnancy before 12 weeks of gestation. From 13 weeks to 20 weeks, a medical practitioner in consultation with the woman is of the opinion that continuation of the pregnancy can pose a risk to the mother's physical or mental health. There's a substantial risk to the fetus, or if the pregnancy resulted from a rape or incest, or continuation of the pregnancy would significantly affect the social or economic circumstance of the woman, that pregnancy can be terminated under those conditions. After the 20th week, and I would put in brackets perhaps here, after 24 weeks really, where viability starts, to become an issue if a medical practitioner, again, together with another practitioner or a midwife, is of the opinion that continuation of the pregnancy will be a serious risk to the mother's health or to the fetus. So before 24 weeks, it is relatively straightforward to terminate the pregnancy because the baby is simply not viable. But after 24 weeks, the moral issues start coming into the equation as well. Can we really, with a clear conscience, offer termination of pregnancy after 24 weeks? And this is where it becomes very, very difficult, and is usually an approach that should involve many stakeholders, from psychiatrists to the fetal medicine specialists to obstetricians, and sometimes obtain legal advice as well. Some people will question even why we discuss these issues, because if we accept that sanctity of life is paramount, then viability becomes irrelevant, whether the fetus is before 24 weeks or after 24 weeks, because simply termination should not be desired. If again we believe that the patient has the right to decide what happens to her own body, again, viability should become irrelevant. Many question the issue of assisted reproductive technology. For individuals or couples facing infertility, assisted reproduction is probably the only option they have to have a child. And some may regard assisted reproduction as standard medical practice and progression, natural progression in medicine. Others may find that we're going too far. And, the question that whether we're going against what nature should be dictating what should happen, or religion, or both. When it comes to multiple pregnancies, and particularly important now with all the assisted reproduction techniques, we have decisions to make. When these multiple pregnancies are complicated by fetal abnormalities, when selective termination of multi-fetal pregnancies is required to achieve a better outcome of those fetuses that were left alive, so that obviously is something that we need to, again, make a decision. But how do we make these decisions? And what does the law and the ethicists around the world say around this? And in cases involving twins and triplets, for example, fetal termination for the preservation of pregnancy is not really justifiable, because it does not increase the likelihood of having a better outcome. But the law also says, and the ethicists will say, that perhaps with higher order multiple pregnancies, quadruplets and more, something should be done, because then obviously the pregnancy is probably doomed to fail. So twins and triplets, a very, very deep, thorough discussion has to be taking place before anything is done. How do the parents feel about feticides? Studies have shown that more than half the couples who had embryo reduction said that they did not really understand the procedure or the consequence fully at the time. Depression for women after reduction were similar to those who had spontaneous abortions. A significant proportion still felt guilt, though they believed the procedure was necessary to save the pregnancy. 93% of patients said that they would make the same decision again despite the stress and grief. Obviously, the aim would be to identify abnormalities, and that's where the early first and second trimester scans come into play, to avoid the issue of feticide after viability. But what is severe enough to justify feticide? Who decides about these things? Well, let's look at who decides. First of all, we need to look at how we counsel our patients. How do we obtain consent? And this slide here highlights the significance to provide such information to the patient that she understands clearly in her own language, and maybe at the level where she can understand and comprehend things about what is the way forward, what is the severity of the abnormality, what does this mean for her baby to be abnormal, and in terms of what is the treatment or treatments available for the child, and what is the long-term prognosis. So is one kidney or no ears or missing ear or no toes or even Down syndrome significant enough to justify termination? Some conditions that are known to be not viable, like trisomy 13, 18, renal agenesis, all the thanatophoric skeletal dysplasias, holoprosencephalus, these conditions usually are self-limiting and not much really there to discuss in terms of whether we're doing a right thing or not to offer termination, obviously always with the agreement of the parents. But some other conditions that are kind of borderline, if you wish, such as Down syndrome, the presence of spina bifida, achondroplasia, dwarfism, some of the cardiac abnormalities, these are not necessarily not viable, and that's where the discussion has to be taken place. In some societies with good medical care and wealthy infrastructure, they say society has a justice-based obligation to look after their disabled, where in Africa, this may be different. So where is the position of the doctors in all this? For example, you may be against termination of the pregnancy, right? So a doctor cannot be forced to provide these services, such as termination or even contraception, because of his own personal beliefs. However, a doctor must provide care to a woman, even if she had a termination, even if he was against the termination. Now that she had a termination and she has retained protests of conception or has developed an infection, that doctor is obliged to offer care. So exercise of autonomy by a patient cannot justifiably oblige a doctor to act in a way that is unacceptable as a matter of individual conscience. Of course, the doctor still has a responsibility to refer the patient to another place, a direct referral, to another place where these services can be offered to her. Cesarean section on demand. Another cartoon that I think highlights the point. What are you talking about? Just lay eggs. No, I want an epidural, says the chicken. So if we look at the guidelines from NICE and the Royal College of Obstetricians and Gynecologists, say that cesarean section is a major operation and should not be offered lightly to everybody. But at the end of the day, and I'm summarizing this slide, if the patient remains certain that cesarean section is the right option for her, then the choice should be respected. And I'm putting as an example a case study here. A patient may decide to deliver a fetally malformed fetus by cesarean section because she believes that the cesarean section will increase the chance of surviving of a child, even if it's only for a few hours. The physician clearly is against that because he knows that the baby is not viable. And that is something that has to be discussed. And at the end of the day, the patient will have to get her way because she is the one who decides and signs the consent. What about the opposite? Should a patient have the right to decline a cesarean section, even if this means that the baby's health is at risk if she doesn't have a Caesar? And these things are very, very difficult to get to the bottom. So I'm nearly done, Mr. Chair. So 2 more slides. This is my second last slide. Children's are not their entire destiny. Much depends on how much and what kind of healthcare, education, housing, food, and love they are provided. After all, no matter how genetically perfect a child is born, if that supernormal, genetically normal child, if you wish, is put in an uncaring environment, she or he will probably not develop nearly as well as a normal or even less than normal child reared in a caring environment. And our task, and we are central in this as doctors, is to create a just society in which imperfect children can thrive. For if we succeed in this task, we may no longer feel a need for perfect children. In my very last slide, in conclusion, ethics in obstetrics and in fetal medicine and the concept of a fetus as a patient. It's an essential dimension that guides us to practice safe medicine, guides the obstetrician as well as the patient, parents, helps balancing beneficence and autonomy-based obligations with professional conscience, and ensures respect for the pregnant woman's autonomy. And be aware of the laws of your own country, because that law defines what can be offered. And I put in brackets the Groningen Protocol in the Netherlands, for example, where in selected cases, feticide can be even performed after the baby is born, shortly after birth, if the baby is severely malformed. In other countries, and South Africa is one of those countries, this would be considered as murder. So you don't want to get into trouble if you practice things that are not described in your country's law. I thank you very much for your attention.